right now, millions of people are walking around with a ticking time bomb inside their blood vessels, and they feel absolutely fine.
Yeah, completely normal.
Right. Usually when we talk about a major medical condition, there's an expectation of a clear, undeniable signal. Like, you break your arm, the x-ray shows a jagged white line, and the doctor just points at it. It is entirely visible.
But step into the world of chronic cardiovascular conditions, and suddenly that visibility just vanishes.
Exactly. So today's deep dive is about the invisible medical detective work used to stop the ultimate silent killer, which is hypertension.
And, we all get our blood pressure checked. You sit on that crinkly paper at the clinic, they pump up the cuff, give you 2 numbers, and you just go on with your day.
Right, you don't even think twice about it.
Exactly. But the sheer volume of clinical knowledge required behind the scenes to accurately diagnose, monitor, and treat those 2 numbers is just staggering.
It really is.
To fully grasp this, we are looking at the comprehensive training framework nurse practitioners use to master hypertension for their board exams. It's a guide called Hypertension, the complete NP board review. We're basically going behind the curtain to see how medical professionals learn to decode a disease that actively hides from them.
Okay, let's unpack this, because before anyone can even treat high blood pressure, they have to understand where it comes from.
Right, and the guide immediately splits the condition into 2 very different beasts. You've got primary hypertension and secondary hypertension.
And primary is the main one, right? The essential hypertension.
Yeah, primary accounts for the vast majority of cases. It's this complex, tangled web of genetics, lifestyle, and just natural aging. There isn't just one single, easily removable cause.
Got it. So what about secondary then?
Well, secondary hypertension means there is a specific underlying and often fixable origin. Imagine a patient has a hidden tumor on their adrenal gland.
Oh, wow.
Yeah, and it is constantly pumping out excess adrenaline. Or perhaps there's a severe narrowing of the primary artery that feeds the kidney.
So if an NP misses a secondary cause, they could just spend years throwing blood pressure medications at a patient without ever addressing the actual root of the problem.
Precisely. Which makes the underlying mechanics, the pathophysiology, just crucial to understand.
Right, so if our blood vessels are like a city's plumbing system, hypertension is like having the municipal water pressure cranked up way too high. The pipes are just constantly stressed.
And eventually, that high pressure damages the appliances hooked up to the system.
Which would be our target organs, right? The brain, the eyes, the kidneys, the heart itself.
Exactly. And building on that plumbing analogy, we also have to look at what happens to the pump. Think of someone going to the gym and doing bicep curls every single day.
The muscle bulks up to handle the heavy resistance.
Right. And the heart does the exact same thing when it has to constantly pump against high blood pressure. The heart muscle bulks up, which is a process called hypertrophy.
But that's a bad thing here.
Very bad. Unlike a bodybuilder, when the heart muscle thickens, it grows inward. The internal chambers actually shrink, and the walls become incredibly stiff.
Wow, so the pump just becomes completely inefficient.
Exactly, which sets the stage for heart failure.
And the forces cranking up that pressure are basically a perfect storm of modern living mixed with genetics. The text specifically lists risk factors like age, family history, obesity, a high sodium diet, chronic kidney disease, diabetes, smoking, and a sedentary lifestyle.
It is a heavy list.
It is, but I want to break down how these actually manipulate the plumbing. A high sodium diet, for example. I mean, I know sodium is bad for blood pressure, but chemically, what is it actually doing inside the vessel?
It really just comes down to basic osmosis. Sodium acts like a magnet for water.
Okay.
So when you consume a heavy amount of sodium, it enters your bloodstream and pulls fluid from your surrounding tissues right into the blood vessels.
So you suddenly have a significantly higher volume of liquid trying to squeeze through a closed pipe system.
Right. More volume in the same amount of space equals higher pressure.
Makes sense. And then smoking.
Smoking, conversely, attacks the pipes themselves. The chemicals in cigarette smoke physically damage the delicate inner lining of the blood vessels, which is called the endothelium.
So the pipes get damaged?
Yeah, and that damage makes the walls sticky, inviting cholesterol and plaque to build up. This physically narrows the pipes.
Same amount of fluid, narrower pipe, the pressure skyrockets.
Exactly. And then obesity acts as a physical multiplier. Every pound of excess adipose tissue requires miles of new microscopic capillaries to supply it with blood.
Miles? Seriously?
Yeah, miles. So the heart literally has to pump blood through a significantly longer, more massive network of pipes, which drastically increases the overall resistance in the system.
But this leads to something that genuinely confuses me. Wait, if the pipes are under that much constant physical stress and the heart is literally changing shape, how is it physically possible there is no pain? When I have a sinus headache, I feel the pressure instantly. Why not here?
What's fascinating here is the specific way our nervous system is wired. We have pain receptors, called nociceptors, in our skin, our joints, our sinuses.
But not in the blood vessels.
Right, we do not have those same stretch-sensitive pain receptors lining the inside of our blood vessels. The human body is incredibly adaptable, often to its own detriment.
Because the blood pressure usually creeps up gradually over years.
Exactly. The body just resets its internal baseline. It accepts the higher pressure as the new normal. You simply do not feel your blood pressure moving from a healthy 120/80 up to a dangerous 150/95.
And it just hides in plain sight.
Until a pipe finally bursts, resulting in a stroke or an organ fails. That contrast between asymptomatic hypertension and severe end organ damage is a core focus of the text.
Which is terrifying. But if it's mostly asymptomatic, how does an NP confidently catch it without just relying on a quick, potentially inaccurate cuff reading at the doctor's office?
Well, proper measurement is a heavily tested protocol for a reason. The guide lays out rigorous diagnostic requirements. The patient needs to have their feet flat on the floor, their arms supported exactly at heart level.
And they have to rest first, right?
Yes. They must rest in a chair for 5 minutes before the cuff is even inflated. Even the physical size of the blood pressure cuff is critical.
What happens if it's the wrong size?
If a practitioner uses a cuff that is too small for a patient's arm, it requires excessive pressure to compress the artery. This artificially inflates the reading on the machine.
Ah, so you get a false high. And what about, white coat syndrome, where people just get nervous at the clinic?
That's a huge factor, which is why the real gold standard goes beyond the clinic walls entirely. The training emphasizes home blood pressure monitoring and ambulatory blood pressure monitoring.
Right, where the patient wears a portable cuff for 24 hours. They take readings while they work, while they eat, and most importantly, while they sleep.
Sleep data is absolutely vital. In a healthy cardiovascular system, blood pressure is supposed to drop, or dip, by about 10 to 20% at night while we rest.
And if it doesn't?
If a patient's blood pressure stays elevated while they are sleeping, they are classified as a non-dipper. That lack of nighttime recovery is one of the strongest red flags for future strokes and heart attacks.
Wow. The detective work doesn't stop at the cuff either. Before a patient even feels sick, practitioners are hunting for early evidence of that target organ damage using specific initial lab evaluations.
Right, like running an EKG, an electrocardiogram, to measure the electrical activity of the heart.
Because remember that bulky, hypertrophied heart muscle we talked about? A thicker muscle conducts electricity differently. So an EKG can reveal that the heart has begun reshaping itself before an ultrasound is ever done.
They also run a basic metabolic panel to check the filtration rate of the kidneys and a urinalysis to check for protein.
Why protein specifically?
The delicate filtering units in the kidneys are essentially tiny tufts of capillaries. If the high blood pressure damages them, they lose their tight seal and start leaking protein into the urine.
So catching that early is the difference between reversing the damage and ending up on dialysis.
Exactly. The guide focuses heavily on strict monitoring, establishing blood pressure goals, appropriate follow-up intervals, and recommended laboratory monitoring.
Okay, so the condition is diagnosed, the baseline is set, and the target organs have been assessed. Now it is time to fight back. Here's where it gets really interesting because the arsenal available is massive.
Yeah, it really is.
It operates on a two-pronged attack, starting with lifestyle management. And we aren't just talking about vague advice to eat better. The foundation includes the DAH diet, sodium restriction, exercise recommendations, weight loss, alcohol moderation, and smoking cessation.
Right, because practitioners have to understand the physiological impact of these specific changes. Take weight loss, for instance. It mechanically alters the cardiovascular system.
Because of the miles of capillaries and fat tissue we mentioned earlier.
Exactly. Dropping even 10 kilograms of body weight significantly reduces the total size in the vascular bed. You are removing excess piping, which directly drops the resistance the heart has to overcome.
But lifestyle management is often just the opening maneuver. The second prong is the medication maze, and it is a beast of a syllabus.
Oh, absolutely. The specific medication classes NPs must memorize are extensive. You have ACE inhibitors, ARBs, thiazide diuretics, calcium channel blockers, beta blockers, loop diuretics, and aldosterone antagonists.
And each class attacks the high water pressure from a completely different biological angle.
Right. Let's look at loop diuretics, for instance. They essentially tell the kidneys to flush out excess sodium and water.
How exactly do they do that?
Inside the kidney, there is a microscopic U-shaped structure called the loop of Henle. Its entire job is to reabsorb sodium and water back into the bloodstream. A loop diuretic chemical blocks that exact reabsorption process.
So the sodium is trapped in the urine, water follows the sodium out of the bottle, blood volume drops, and therefore blood pressure drops.
You got it. And then calcium channel blockers take a more structural approach. Calcium is the signal that tells muscle cells to contract.
So these medications block calcium from entering the smooth muscle cells that line the walls of the blood vessels.
Exactly. Without that calcium, the vessels relax, the pipes physically widen, and the pressure decreases.
That makes sense. But how does an NP keep the side effects straight when there are so many options? Navigating these drugs isn't just about how they work, it's about mastering their incredibly specific side effects. Some of them sound bizarre, like the ACE inhibitor cough. Why would a blood pressure pill cause a hacking cough?
That is a classic NP board pearl. ACE inhibitors block an enzyme responsible for tightening blood vessels. However, that exact same enzyme also has a second job.
Which is?
It breaks down a specific protein in the lungs called bradykinin. When you introduce the medication to block the enzyme, you successfully lower the blood pressure, but you also stop the breakdown of bradykinin.
So it just builds up.
Yes, it accumulates in the lung tissue, irritating the airways and producing a dry, persistent cough in about 10 to 20% of patients. It can also cause a life-threatening swelling called angioedema.
Oh, wow. So a practitioner has to know that if a patient comes back complaining of a lingering cough, it's not a respiratory infection, it's the medication modifying their lung chemistry.
Right. And knowing what to do next is a crucial first-line medication selection skill. They need to pivot to a different class, like ARBs, which are angiotensin II receptor blockers.
And ARBs target the exact same blood pressure pathway as ACE inhibitors, but they block it further down the chain, right?
Exactly. They completely bypass the enzyme that affects the lungs, which eliminates the cough. Memorizing these medication contraindications is really just a matter of patient safety.
The text also mentions hyperkalemia, which is abnormally high potassium in the blood, and electrolyte abnormalities, bradycardia, and peripheral edema.
Yeah, take hyperkalemia. Potassium is the key electrolyte that controls the electrical firing of the heart rhythm. Several blood pressure medications, like ACE inhibitors and aldosterone antagonists, cause the body to retain potassium.
So if you prescribe those to a patient whose potassium levels are already borderline high, you could trigger a fatal cardiac arrhythmia.
Precisely. This is exactly why the text includes those NP board pearls. Picking a drug isn't just about the medication itself. It's highly dependent on who the patient is, bringing us to the most complex part of the board review.
Right. Treating a textbook case of isolated high blood pressure is rare. Usually the patient has other issues, which introduces the concept of special populations.
And it is full of common board traps. Determining blood pressure goals based on comorbidities is a major one. You have to tailor care for diabetes, chronic kidney disease, heart failure, older adults, pregnancy, and Black adults.
Diabetes is a huge one, right?
It's the perfect example of how complex this gets. In a diabetic patient, the kidneys are highly vulnerable to damage. Clinical guidelines often dictate that an ACE inhibitor or an ARB must be the first-line treatment for these patients.
Even if their blood pressure isn't catastrophically high.
Exactly, because you're using the side effect profile as a targeted therapy. ACE inhibitors specifically dilate the exit pipe of the kidney's filtering unit. By widening the exit pipe, they dramatically reduce the pressure inside the filter itself,
offering profound mechanical protection to the kidney that other blood pressure medications simply do not provide. But then you have variables that completely upend the rule book. Pregnancy is a massive variable. I noticed pregnancy considerations has its own specific call-out under medication side effects and special populations.
Oh, absolutely. Many of these foundational medications, specifically ACE inhibitors and ARBs, are strictly teratogenic.
Meaning they harm the fetus.
Right. They interfere with fetal kidney development and can cause severe birth defects or fetal death. A practitioner must instantly recognize that a pregnant patient requires a complete pivot to safe alternatives.
Demographic profiles also shift the starting line, right? Extensive population-level clinical trial data shows that Black adults often have a different physiological profile regarding the renin-angiotensin system.
Yes, that's a major hormone cascade that regulates blood pressure. Because this specific system is often less active in Black patients, medications that target it, like ACE inhibitors, are generally less effective as a starting point.
So standard guidelines instead recommend initiating treatment with a thiazide diuretic or a calcium channel blocker for Black adults without heart failure.
Right, those mechanics yield much better initial control.
So what does this all mean when those carefully calculated long-term plans fail? The training framework eventually forces practitioners to confront the absolute extremes, which is hypertensive crisis.
This is when the silent killer suddenly gets very loud. Blood pressure spikes to dangerous levels, typically defined as a systolic top number over 180, or a diastolic bottom number over 120.
At those extreme numbers, practitioners have to make immediate decisions.
But they must first differentiate between two drastically different clinical realities. You have hypertensive urgency and hypertensive emergency.
The numbers on the cuff might look identical in both scenarios, right?
Exactly. But the treatment protocols are complete opposites.
Okay, so in hypertensive urgency, the numbers are terrifyingly high, but the target organs haven't begun to fail yet. The pipes are under maximum strain, but they aren't bursting. Maybe the patient ran out of their medication a week ago and experienced a rebound spike.
In that scenario of urgency, the goal is actually to lower the blood pressure gradually over a period of 24 to 48 hours, usually using oral medications.
Why not just drop it immediately?
Because the brain is accustomed to that high pressure to maintain its blood flow.
Yeah.
If you panic and artificially crash their blood pressure back to 120 over 80 in a matter of minutes, you can drastically underperfuse the brain.
Wait, really? You could cause a stroke by lowering it too fast.
Yes, you can actually cause an ischemic stroke.
That is a terrifying board trap. But hypertensive emergency is a different story entirely. That is when the high numbers are actively tearing the system apart.
Identifying hypertensive emergency is crucial. It means acute, ongoing target organ damage is happening right in front of you.
Like what exactly?
Well, a blood vessel in the brain might have ruptured, or the inner lining of the aorta is tearing. The heart could be failing to pump fluid, which causes the lungs to fill with water.
So in an emergency, the slow and steady approach is discarded.
Completely. The patient must be immediately transferred to an emergency department. Knowing when to refer a patient is a required NP skill.
Because they need intravenous medications to rapidly but carefully drop the pressure and stop the mechanical destruction of the organs.
It is a high-wire act of biochemical management. The board exams test this heavily, including navigating resistant hypertension or secondary causes.
Right, they want to know if a practitioner can recognize when a patient has crossed the line from a chronic management case into a critical emergency requiring immediate escalation.
Which is exactly why the training culminates in complex practice cases. The text uses 10 to 20 NP board-style case scenarios with detailed rationales.
So the exams don't just ask for definitions of terms.
No, they present intricate, multi-layered patient profiles designed to test these exact life-or-death decisions.
It is truly invisible engineering at its finest. Just looking back at what we've unpacked, the incredible scope of knowledge required by NPs is amazing. From understanding the DHH diet and ambulatory monitoring to navigating ACE inhibitor coughs and hypertensive emergencies.
Absolutely. And for you listening, this exploration should completely reframe that mundane blood pressure check at your annual physical. The professional reading those numbers isn't just logging data into a chart.
Right. They are analyzing a vast algorithmic matrix designed to protect the microscopic integrity of every organ in your body.
It's a massive, unseen effort hidden behind that simple cuff reading.
It makes you appreciate the invisible expertise required to tame the silent killer. And it leaves me with a final thought for you to ponder. The guide ends with those 10 to 20 highly detailed practice cases. If you were handed one of those patient files right now, armed only with their age, a list of subtle symptoms, and a single lab result showing slightly elevated kidney enzymes, how confident would you be in dodging the common board traps and choosing the exact right first-line medication to save their target organs?